Good morning, everyone. Magandang buhay sa lahat. Okay, this is the latest statistics shared by UN and show that more than half of the older persons in the world are occupied by Asians, and we belong to that group. Here in the Philippines, according to PSA 2016, this is the latest that I could get, older individuals comprise 7.5% or a total of 7.5 million individuals. Our increasing number of older persons put our country alongside Japan, China, and South Korea. No country has beaten Japan yet when it comes to the number of older persons. However, according to projections made by the Commission of Population and Development, the number of older persons are continuously increasing in the Philippines. So the Philippines is not exempted from global aging. What is in store for us in this new normal? My agenda, after my talk, you will be able to explain the conditions that bring about vulnerability and frailty. From the glimpse on vulnerability and frailty, I hope you will be able to situate nursing care in terms of problem identification, appropriate tools for assessment, and intervention. Allow me to share with you some terminologies. Frailty is a modern geriatric giant, a major public health problem in the older population. And it is defined by the International Association as a reduced strength and physiologic malfunctioning that increases an individual's susceptibility to increase dependency, vulnerability, and death. It is widely accepted that we are all undergoing deteriorative process which exists in nature, and we need to expend much energy and material resources in order to combat these processes. Frailty is used as a marker of adverse outcome in older adults, and in oncology, cardiology, and orthopedics, it is increasingly used to predict patient outcomes after treatment. Vulnerability. As mentioned, frailty leads to vulnerability, and it is an increased risk of functional decline or death over a period of 2 years in relation to biological and physiological factors. The formula is that vulnerability is equivalent to the summation of the exposure, resistance, and resilience. Exposure is the risk that the individual actually is exposed or is in the environment. Resistance are the measures taken to prevent or avoid. So this is more or less equivalent to our promotive and disease prevention interventions. And resilience is the ability to recover to prior state or the best optimum health that they could have. Okay, this is actually a life course approach to aging. Aging resulting to decreased physiologic reserves is actually one of the exposures to vulnerability and frailty. Age, which is the progressive generalized deterioration in function post-maturity, can be considered as biological aging. If you notice, from start of life up to the end of life, we are exposed to risk factors. And the physiologic reserve actually has its peak between the ages of 25 to 30. However, at age 30, it undergoes normal decline. And if you would not know, not all of us notice, but our body is actually undergoing physiologic decline at the age of 30. If you will follow the line B, that is when the individual has suboptimal development due to the risk factors. Line C actually is the accelerated age decline, which can happen due to risk factors as well. D is the combination of B and C. So B, C, and D are declines due to the exposure to risk factors. At risk for frailty, these are also the exposures, genetic aging, which as I have mentioned, immunity and inflammation actually are destructive to our cellular processes. Nutrition imbalance, protein energy malnutrition, systemic disease, insulin resistance, hormonal problems like testosterone, insulin growth like factors, and vitamin D. All these that I've mentioned leads to sarcopenia or progressive muscle wasting or decreased uh, bone mass, which could actually lead to functional decline. Non-adherence to healthy lifestyle, polypharmacy with a lot of morbidities in older person, the drug-to-drug interaction, drug-to-body interaction, and drug-to-food interaction can also actually contribute to frailty. Being female, since female has the longest lifespan, is also a risk factor. Social isolation and poverty were mentioned by the International Association of Asia Pacific and in the study of Bolot. This is actually a local study, and it was recently shared by Dr. De La Vega, that among our older persons, those 80 and above are actually the highest risk because they need assistance in ADL, poor functional ability, history and fear of falling, poor oral health, poor nutrition. The oral health contributes to malnutrition as well. And frail according to their objective assessment using the time up and go, 6-minute walk test, and the functional rates. As I mentioned, vulnerability is the ability to suffer harm or loss. But both vulnerability, the resistance, and the resilience are determined by the physical, environmental, social, economic, political, cultural, and institutional factors. Truly, the picture of the health situation of an older person is incomplete if we will not look at the social determinants of health. This model, multi-level approach to epidemiology, is showing that individual life course and environment affects one's health condition. Epidemiology deals with the incidence, distribution, and possible control of disease and other factors relating to health. In a way, it will give you an idea of how we will manage frailty and vulnerability. The model attempts to map the relationship between the individual and the social determinants of health. The first three rectangles actually are what constitute the intrinsic factor of the individual and the disease that could happen due to the genetic makeup as well as their sex. The individual behaviors are affected also by the social and community, which is actually the next two squares. It could affect the behavior of the individual. It either affect positively or negatively. And the last two rectangles include structural factors, housing, working condition, access to services, and provision of essential facilities. All these affect the state of health of an individual and thus affect the health of the older persons. COVID-19, this is that means I made this my PowerPoint plus October 25. We still have a lot of COVID cases, and COVID is another exposure when it comes to frailty and vulnerability. The older person's decreased physiologic reserve and the presence of comorbidities actually made them susceptible to contacting COVID. And whether they are affected by it or not, it is actually considered a risk factors because of the effects that it has on the older person. Okay, so I am using this because aging, social determinants of health, and the pandemic resulted to interrelated and interdependent effects on the older persons. It actually includes economic, life and death, mental health, vulnerability, responders, and abuse, and neglect. Economic well-being. According to UN, the pandemic may significantly lower older persons' income and living standards. In the world, 20% of older persons of retirement age are receiving pension. In the Philippines, according to the Senate report, 7.5 million senior citizens, only 30% receive social pension equivalent to 500, and 40% receive no pension at all. The remaining 30% actually are those receiving from SSS and GSIS. With the imposition of the community quarantine, wherein the older persons are prohibited from leaving their home, their economic well-being are also challenged. Some of them are still work, majority of them in the informal sector, and have been deprived of their main source of livelihood. The retrenchment of OFW. Some of our older persons are relying on their relatives and children who are actually working as OFW. In the context of pandemic, the economic security of older Filipinos heightens their vulnerabilities in terms of inability to access healthcare and to pay for healthcare bills. Although shared efforts have been done by the government in providing for the economic stability of the older persons, the guidelines, the remoteness of the older persons actually lead to dissatisfaction and inequalities. Overall, it's not just advanced age and medical comorbidities that make older Filipinos vulnerable to COVID-19, but poverty also plays a significant role in their high death rates. Life and death. As you can see in this slide, according to CDC, compared to ages 18 to 29, there is an increased risk of hospitalization among older persons. And as you just mentioned, those 85 and above, they are 11 times higher hospitalized than the comparative age. Death-wise, which is below, among those who are aged 85 and above, actually have 630 times higher than those 18 to 25. In the Philippines, this is the latest data which includes the older person. I have presented this during our frailty seminar, but this is only the only one available. It showed that the older persons have lesser way of contacting COVID. Only a few of them are contacting COVID. However, if you would look at the diagram below, though there is a small number of older persons affected, majority of them died. So that is the effect on the life and death of the older persons by the exposures. Mental health. Physical distancing can take a heavy toll on our mental health. The strong faith and spirituality of older Filipinos serve as strength and protective buffer to stress and suffering. Going to church regularly and attending church activities and gatherings are part of our everyday life. And to be banned from doing so is already a threat to our mobility and to our well-being. The onset of new pandemic, for which all of us has no experience, has also a toll on the older persons. They chose to be housebound, venturing only when extremely necessary, and this actually cause isolation. Some may experience depressive symptoms, loneliness, pessimism, deterioration in cognition, and disruption in sleeping patterns. Social connectedness and engagement are very important to promote successful aging, but this is disrupted by the restrictions or physical distancing. The disruption of everyday activities of the older persons actually lead to cognitive impairments. In fact, among those patients with dementia, they have observed increased behavioral manifestations. Vulnerability. Essential care of the older persons are sometimes reliant on the caregivers. In the institution, Only few caregivers are available, and what is worse is also the visiting hours are either cut or limited. This brings isolation to older persons and limited care. For those who are in the home, it is another concept in our culture that multi-generational households actually a lot of people are staying in one house. And this is probably good if there is an hacienda. But in other places, this the house is not capable actually of isolating the individual if one member of the family is affected. So this predisposes not only the other members of the family, but also the older persons. The carriers also are the ones going out to earn a living, so they are predisposed to having the infection. And this could be transmitted to older persons. Responders, in a home setting where there are only two older persons, either one of them is a caregiver. And if there are only two of them, they are one older persons will also be the one who will go out to get their needs, and therefore they are also prone to contacting infection. Also, the older persons are sometimes the carrier of their sick children, of their apos who are left behind by their children, and therefore actually affect the state of health of the older persons. And I think this is the last slide of the effects of COVID, abuse and neglect. According to UN, in 2017, 1 in 6 older persons were subjected to abuse. However, it is also stated in the report that more cases of violence against older persons is on the rise. Our Human Rights Commission on Human Rights Commission claim that 40% of our older persons are abused of some kind. However, they do not have data to support this. In fact, in the presentation of the Coalition of Services of the Elderly, they mentioned that elderly Filipinos often become the subject of discrimination, ridicule, and even abuse. Some consider them merely as objects of charity and not individuals with inherent equal and universal rights as other members of the society. Ageism can be considered a form of abuse. Caregivers burden. All of us are burdened by this pandemic. And if the caregiver is burdened, poor quality care would actually be given to older persons. So nursing process is a given way of caring for the older persons. And make sure in the assessment, in making the nursing diagnosis and intervening, we have to see to it that the exposures, the aging, the social determinants of health and COVID are taken into consideration. We also have to look at what are the promotive and preventive measures that were done by the older persons and what are the resilience. More importantly, it is very vital that we focus on the responses of the older persons and the family to the presence of frailty and vulnerability. Actually, tools are available in assessing. A lot of tools for vulnerability. There is what we call vulnerability of elderly survey. There are actually frailty tools. However, majority of the studies mention the comprehensive geriatric assessment. It is a 14-page assessment tool, but you don't need to do it in one sitting. You can do a focus assessment initially and then continue. The importance of CGA actually is that it looks at the functional ability of the older persons. It looks at the goals that the older persons and the family wanted to attain. And it also includes the psychosocial and emotional as well as spirituality of the older persons. Okay, so in intervening, I am still recommending the RISE model. So the RISE model actually are repair and restore optimum health status of the individual. And we can do this if we will look into the exposures of the individual. What are the resistance that has been done by the older individual and the healthcare system? So utilization of the nursing process and assessing all the exposure would help us in repairing and restoring optimum health status. Intra and interpersonal relationship. It is important that we know how the older persons perceive oneself. How is he relating to other members of the family and the community? We have to have that deeper feelings of shared responsibility with a common goal of surpassing this pandemic. A very important part is collaboration and coordination of all stakeholders, the nurses and other health professionals, the social services need to talk to each other in order to come up with the best solution to the problems of the older persons and even the human rights. And as I have learned, we have to do the 3 Rs. It means rethink. What are the interventions that we think are very useful and can be successful during this crisis? And if ever we think of some measures to improve the care, we have to make sure that it is evidence-based. So research is the second R. And of course, the third is redesigning with the observation and the rethinking and then research, then we can redesign ways to actually combat the frailty and vulnerability of the older persons. Empowering everyone is very important. The care of the older persons rely on the family. So the family and the older persons herself should be empowered. Even the young generation, they should be empowered because they are the future older persons of our country. And in empowering, we have to put in mind that what we wanted to develop is resilience, not dependence. And I would like to share this with you. In every community, there is work to be done. In every nation, there are wounds to heal. In every heart, there is the power to do it. And I hope we have the manus caput cor in order to help the older persons.